for a safe space where healing might take place, where everyone is valued. Given tools to maintain where equity matters. Less talk, more action, where anyone is welcome. Don't send them home packing, this is strong talk. When conversation pops off, speak life, reflect hope, promote choice and love folk. Strong talk, real talk, no jokes. Recovery, culture, community. Let's go.
Hello and welcome to Strong Talk, a podcast dedicated to the discussion of equity, diversity, and family as it relates to mental health and addiction. A space not only to talk about challenges, but to explore and to create space for solutions. I'm your host, Vic Armstrong, and I want to thank you all for joining me on this journey. Today, I'm joined by my good friend, Akemie Jones, Learning and Development Manager at Recovery Innovations International. Good afternoon, Akemie.
Good afternoon. Hi, Vic. How are you doing?
I am doing well. Thank you so much for joining me.
Thank you. Thank you for having me. I'm excited to be here.
Yeah, and in this space, we talk about access, we talk about equity, we talk about family. And so I wanted to bring you on because you have a very rich and very full career, but also very interesting career in some of the things that you've seen and been able to do in this mental health space. So I'd love to start with just a little bit of background. What brought you to this space? What's your career path been like?
So I am in the mental health field because I believe in individuals having whole person wellness, right? We're in America, we're accustomed to us going to the doctor for our physical bodies, but what about our mental health? And there's such a importance for making sure that we have sound bodies and sound minds. We make a lot of decisions during the day. Our emotions impact the decisions we make during the day. And if we are not attuning and self-aware of what's happening up here, then it impacts everything else. So I'm very passionate about helping people with their mental health and their self-awareness so that they can lead full, successful lives.
Yeah, that's fantastic. It also brings something else to mind for me because oftentimes when I talk about equity, because I do a lot of work, as you have in the mental health space, but squarely over the last several years, I've really been focusing on health equity and access to care. And one of the things that people often do when you start talking about equity is that they automatically fixate on race and ethnicity, but miss kind of the intersectionality, all those things, other things that can make a person historically marginalized. And one of the things that I have always argued is that people who live with mental health challenges or people who experience mental health emergencies are and always have been historically marginalized and really face challenges in not just in access and care, but also some of the stigma that comes with being a person who lives with mental health challenges. Can you talk a little bit about that? What do you see for people who live with mental health challenges as being things that we as providers in this space need to be thinking about?
Well, when you think about individuals that have mental health, we say, well, how come they don't seek treatment? Well, because here in America, people say, well, if you have a mental illness or if you're on substances, you're considered weak. You're not considered worthy. People are ashamed to admit that they need help with these things. And it will always kind of baffle me as to why we do that, right? If it was easy for an individual to stop using a substance, they would stop. If it was easy for an individual to not be depressed, if it was easy for a person to be functional, then they would do so, right? They're seeking help so that they can regain their functionality. And we really should not put stigma and barriers in place for those individuals. So that keeps people from looking for their resources. It keeps people from saying, hey, I need help with this particular issue, with this particular concern. They make it very embarrassing. And there's a lot of people out there that you and I, Vic, know are suffering, and they don't know how to seek help the right way.
And in the work you do with RI, with Recovery Innovations, you work primarily in a crisis space, correct?
Yes,
and
in a crisis. Mm-hmm.
So you see people when they're really oftentimes at their most vulnerable, and really most in need of human connection, but also human compassion. And so that mindset that, if you have that, even as a provider, if you have that mindset that a person should do better, it really can create a lot of challenges in meeting that person at their point of need.
Absolutely. Like it means we're not meeting them where they are, right? For
Yeah.
us to have unrealistic expectations of people that are presenting to us with these mental health and substance abuse challenges makes no sense, right? When you go to a doctor and let's say you have high cholesterol or you're overweight, does your doctor say, well, I just thought you'd weigh a little bit less this time, but your doctor knows you're not exercising, your blood, your cholesterol, all of your things are out of whack. They don't hold you to necessarily unrealistic expectations in that field. They meet you where you are, they give you a treatment plan, and then you check in. Same concept is what should happen when individuals present for crisis. Meet them where they are, right? This might be their first time. And oftentimes in crisis, we are that first step, right? Person comes to us when they are at their ultimate low, right? So we should have no expectations outside of we are here to help. We're here to give you the help that you want, not the help that we think you need, right? Because what we think you might be different than what you actually need. So as providers, we must be open to having these conversations of humility. So I think providers need to be more humble and say, hey, I'm an expert in my field, but I am not an expert of the person that's sitting across from me. And I need to make sure that I am creating this space sitting across from me to actually tell me what they need and how I can come alongside them and support them. Because as providers, we don't have all of the answers, right? It's a collaborative experience that we should be offering to our guests or patients that we're serving within our communities.
So can you talk a little bit more about that? What would you say to a provider in terms of the provider's responsibility to make that a collaborative experience, and then also just in terms of how we create the atmosphere, how we create the space that we see people in, what should be the role of lived experience in forming that space?
I think one of the first things that any provider should do, and in full transparency, it doesn't matter what field you're in, provider, every time they meet with a patient, they should acknowledge, okay, what am I seeing when I see this person, right? Because we have our own process when we interact with individuals. Am I self-aware? Am I seeing this person as a human that is coming to me for collaborative expertise for us to work together? When I look at Akemie, do I see, oh, this is just a Black female? She might be on Medicaid. She might not have education. Am I coming into these engagements with preconceived bias or stereotypes that create barriers? So being very self-aware of what we're bringing as providers into every interaction, because we already as providers are on this kind of like a hierarchy or a pedestal, not because we choose to be, it's because we are deemed the expert. So how do we go from here to here with those that we serve? What are the questions that we can ask in our assessment? What is the atmosphere that we can create? All the way up to how do we greet the patients that come into us, right? When we come to our office, I've had some experiences with providers where they don't even look at me in the eye. I remember several situations after I gave birth to my daughter where the doctor, she'd come in, she wouldn't make any eye contact with me. She'd go right to the computer. Yep. Head circumference is fine. Everything's yep. Any questions? Nope. Goodbye. There was no sense of human connection there. And that made me uncomfortable going deep into some of the questions that I had, because I already felt like I wouldn't be heard. And providers, whether we believe it or not, our patients, our guests, those that we serve, can pick up on whether or not we're genuine, right? They can pick up on whether or not we're doing this just to do it for the day and move on to the next patient, or if we're truly here to create a space for them to heal. So we need to be cognizant and knowledgeable of the spaces that we are creating. Are we creating spaces to hold people, spaces for them to truly be themselves? And lived experience is so important. We are not the expert in people's lives, they are. And we need to humbly collaborate with those individuals.
Yeah, a lot of richness in what you just shared. But one thing caught my attention. You referred to people who come into your organization as guests. Where does that come from? Why do you refer to them as guests?
Yes. So whenever you say the word guest, doesn't it come with this feeling of, oh, I need to honor their presence when they're with us, right? They're choosing to be here. A guest chooses to be a place. They don't have to be here. So I think when we're here at Recovery Innovations, when we refer to our demographic as guests, it's because it keeps us as employees or team members aware that we are here to serve, right? We're not here to tell people what to do. We don't always know what's best for people, but we are going to meet them where they are at whatever door they present to within our programs and treat them as guests, make them feel welcome. If they have a difficult time reading or if they have a difficult time writing, we don't shame, we come alongside and we help fill those gaps, right? We're treating people as guests, treating people how they want to be treated. I think it's so common for us to hear that golden rule. When you think about it, treat people how you want to be treated. Well, how I want to be treated might not be how Vic wants to be treated, right? So if Vic was my provider, Vic would need to make sure that he's connecting with me the way that I would like to be connected with in order to yield the best results for that person.
So it would seem to me that this would need to be part art and part science. And by that, I mean, it does seem like as a provider, there's a need to be intuitive. There's a need to be willing to meet a person at their point of need, to understand and that it needs to be a collaborative relationship. But there also, especially as a part of an organization, would need to be some structure, some process, some procedures put in place that reminds that provider to do that, or some things put in place so that that becomes a part of the way that an organization provides services. Because oftentimes those processes and procedures help to make sure that you're adhering to that culture. Can you talk about that balance? How do you as a provider strike that balance between the things that you know that you clearly articulate, but then what things are built into your system that also reinforce those values?
Sounds like we're talking about the my expertise as well as like the art of connection, right? Because you can know all of the things that you know, but if you're not able to relay those things well, if you're not able to reinforce the importance of those things within your programs, policies, and or procedures, it's going to be difficult to be consistent. The biggest thing that I can say, especially where I am now, is the engagement piece. And I'm not sure if that's the exact answer that you're looking for, but making sure that we are touching our guests often, right? Checking in with them. Is this correct? Like, am I on the right vein here? And making sure that every single team member that comes after me or even before me is doing the same thing. We're never moving forward with 100% confidence that what we have is correct, right? We're always circling back around in every single process and every single step to say, hey, Vic, this is what we have as a team. Are you in agreement with it? And to be honest, I think I could probably count on my hands how many times a provider has asked me if I am in agreement with the treatment plan and our course that is made for me. But that is something that is built into our structure here, is making sure that we are engaging, we're checking in. We have that lived experience piece as well as far as peer support specialists. So we're checking in often. Is everything okay? Do we need to change anything? If the guest says, yeah, you're kind of on the right track, but you missed it over here, can we change it? Absolutely. Why not? Right? We're making decisions with, right? We're having conversations with and not at. So I do believe how we choose to engage, you can have all of the policies and procedures in the world, but if you are not creating an environment that's built on true engagement, which is that art of connectivity, then in full transparency, what are we doing?
Yeah. And, one of the things too that I think is true of no matter how you're thinking about historically marginalized people, historically marginalized communities, oftentimes I think what creates more of a spirit of acceptance, of inclusion is relationship. It's much easier to fear or demonize people when you don't know those people. But you mentioned lived experience and having people with lived experience on your team, and that's got to be helpful in terms of because we all can have blind spots, and we all sometimes need to be reminded that hey, that may resonate differently with the guest than how you intended, and to be able to help give us that consistent feedback. Can you talk a little bit about what that looks like in terms of lived experience in your workspace and how that helps you as a provider and as a leader?
Yes, absolutely. So when he's referring to lived experience, we're referring to our peer support specialists. And so peer support specialists are individuals that have their own personal lived experience with mental health challenges and or substance use challenges. And one of the reasons we employ those individuals heavily within our program. So it really doesn't matter what program you go to within Recovery Innovations, there's always going to be more peer support specialists there than any other discipline, because we want those guests that present to us, be it at a crisis facility, outpatient, what have you, we want them seeing individuals that have gone through to some degree what they've been through. Now, keep in mind, everyone's lived experience has its own little remix or customized version to it because it's their lived experience. But I can still say, I know what pain feels like from this degree if there's another guest that's going through that same thing, right? It's that shared experience. So that way we're then creating this environment that's not necessarily excuse me, clinician and medically heavy, right? It's a well-rounded, integrated team that says, hey, we have this medical piece, we have this clinical piece, and we also have this lived experience piece where we come together to have this well-rounded engagement piece for our guests, so they can truly feel seen, right? I believe that when guests present to us, they want to know, do they see me? What do you see when you see me? What do you hear when you hear me talk? Do you actually hear my pain? Do you see that this is not as easy to do as you may believe it is? Or are you seeing something else? And making sure that we have peer support specialists, that viewpoint allows us, as clinicians to be humble, as nurses and medical professionals to be humble, to remember it. Yes, we have this textbook knowledge, but we have to connect with people. And in full transparency, we probably could all be peer support specialists to some degree. I know what depression feels like, right? Especially coming off of having a child. I definitely struggled with some postpartum. So it's not easy, right? It's not easy. And most of us are probably always kind of teeter-tottering on that. I'm functional, I'm not functional, I'm functional, I'm not functional. And so we're wanting to make sure that we're engaging with people that see us, that see that this is not easy and I need your support.
Yeah, and part of one of the things I love about what you just shared too is that when we talk about diversity, equity, and inclusion, oftentimes we at least theoretically understand the diversity and the equity piece. The inclusion piece is the one that oftentimes we struggle with, because we can bring diverse people into the workspace. We can put policies in place that address equity, but it's that inclusion piece of people actually having space to use their voice that often can be challenging, in part because we often fear people saying things that really put us on notice or tell us what we're doing wrong. But it sounds like in your workspace, those peers actually have a voice in terms of informing the work and how the work should be done.
Yes, we want their feedback, right? If I remember when I used to work on our direct care units, and I remember I would work very closely with my peer support specialist teammates to say, hey guys, this is what I'm getting from the initial assessment that I got. I want to make sure that I'm not misinterpreting, that I'm not translating it incorrectly. And sometimes me and that peer would sit down with that guest to make sure that I am creating the space, right? Creating that space so that person feels seen. Because sometimes it doesn't matter, right, how much we try to make a person feel seen, we might not be the best person to do it, right? And this is where like pride and ego can get in the way. Like, why wouldn't they want to talk to me? I have all the schooling, I know what to do. Sometimes we need to, as providers, we need to say, something I'm doing isn't quite getting through. So I need to tap out maybe and tap someone else in that's able to kind of breach that barrier, right? That can kind of be that warm handoff for me, so that person can see me as genuinely wanting to help. And I know that probably doesn't happen a lot. I do believe that is something that might be very unique to our organization, that we can easily tap team members in and out as we need to based off of the guest's needs. So it's not how quickly I need to get an assessment done. It'll get done when it gets done. We need to make sure that this guest feels seen and heard and respected, or else the information we get isn't going to be helpful, because they're not going to be genuine with us. They're not going to be 100% open with us. So we have to take the time to create those spaces and places for our guests.
Now, I want to make sure I understand this, because that is a unique perspective. When you say, assessment gets done when it gets done, so you're actually telling me that you don't have a checklist that I've got to do this, and this. You actually can move in ways that really cater more to the needs of that person at that point in time, as opposed to, let me make sure I check off all these boxes.
Exactly. So, of course, just like any other organization, we have checklists and boxes in order to keep us organized. But organization of the process doesn't run the process, right? Sometimes there are those instances where we have to say, okay, I know I need to do XYZ, but this isn't going to work for this particular individual. So I need to step outside of the box, right? I've checked in with this person. They still might not be ready to have an assessment with me. Or I notice that when I get close to this person, they might shy away. Not because I've done anything wrong, right? I'm just being very self-aware of, something's off here. Okay, let me tap out for a minute. And let me bring someone else in here that can help build this foundation of trust, right? And then maybe I can get pulled in to say, okay, I just need to ask you a couple of questions. I just need to confirm why you're here. We want to make sure you're getting the help that you need. But if I come in hot and heavy, even after seeing that Vic is kind of shying away from me every time I come in, and I'm like, okay, got to come in and do an assessment with you, Vic. It won't take too long. Can you explain to me why you're here? Vic's like, I have no desire to talk to this person. I'm scared or I'm not comfortable. And I'm choosing as a provider not to acknowledge, more often than not, it's nonverbal. The nonverbal cues that my patient or guest is giving me. So I do like that our organization gives us that flexibility of our integrated team or interdisciplinary team to say, hey, can I get some support on this? Can I make sure this person has what they need? I know that's unique and it's not something that every provider has the ability to do. But I would, if there was a takeaway from this particular section, it's how can I eliminate as many barriers as I can so I can make sure that the care that I'm giving is the care that is truly needed. Right? How can I make sure that I'm truly giving that person what they came here for? And sometimes that means I need to talk a whole lot less and I need to bring someone else in that's able to assist me, partner with me in doing that. I don't have all of the answers, but I do think we need to partner with individuals that have lived experience a whole lot more.
You know, I for years I ran a mental health hospital, and one of the things that I would often challenge my staff to think about was if you or your family member were experiencing a mental health emergency, is this a space that you'd want them seen in? If they have to go inpatient, is this a space that you would want them to have to live in and be housed in? And I can tell you, based on what you're describing, I mean, God forbid that I or my, a member of my family ever needed emergency mental health services. But what you're describing is exactly what I would want for a loved one. I'd want my loved one to go to a space where they felt like they matter. Not that they're being moved through a process for the sake of drawing down money, but that they're being treated as if they are the most important thing to that provider at that time. One of the things that I've often struggled with in the design of our mental health system, and especially our system as it responds to people experiencing mental health emergencies, is that we created a system that was not designed to protect and nurture the person that was experiencing the emergency or the crisis, as we call it. We created a system that was designed to protect the rest of us from that individual, and that is a flaw in the system. But it sounds like the approach that you've taken, that Recovery Innovations has taken, is really the opposite of that. It really is meeting that person at that point of need. To that end, though, I want to ask you, because you've been in this mental health space for a while now, for a number of years. As a system, I'm curious, do you feel like as a system we're trending in the right direction? Are there things that you've seen, not only at RI, but at other organizations, or the way that we approach the conversation around mental health, that lead you to believe that we're trending in the right direction? And are there any specific things that tell you that?
That's a great question, Vic. I do believe that we are starting to trend in the right direction. So, of course, we have 988 that's out there now. And that space, that's supposedly a safe space for those of us that are struggling with mental health and substance use, to call that number versus 911. But in a lot of the community meetings and events and things that I've gone to, I've started to hear about the lived experience piece getting added to like mobile response or riding with the police when they go out for calls, or riding with community paramedics. So that lets me know that we're all saying, there's something to this, having the ability to tap someone else in that may be better appropriate for the situation, right? And this isn't to say that those individuals that are in law enforcement or paramedics that they are doing a disservice, but just we have to keep in mind that those uniforms come with their own stigmas, right? That can make it difficult or challenging for individuals, especially in marginalized communities, to feel safe in that space, right?
Mm-hmm.
So these individuals are now acknowledging that and saying, okay, we have to call a spade a spade. We hate that it is this way, but once we acknowledge that it's a problem, then we can what? Address the problem. So now we're getting this lived experience piece across a multitude of different service types to ensure, again, that people feel seen and not threatened when they're asking for help, that they feel seen and not shrunken when they're asking for help. So I can say, Vic, that I do believe that we are starting to trend in that right direction. And I'm excited to see where the next, 3 or so years brings us.
Yeah, I would tend to agree. And I think when you bring up 988, I think that is both. I think it's definitely an opportunity for us to really think about and reimagine how we approach, particularly emergency mental health care, and it provides us with so many opportunities. And it does my heart good to hear some of what you talked about the way that RI is already approaching that. And I think with the availability of 988 now, I think there's just so many other opportunities for us to do that across the board with other organizations, to think more collaboratively about how we collaborate with other community stakeholders, and especially those individuals in the communities where we live in, with lived experience. So,
Vic, real quick on that vein, I think one of the things when it comes directly to 988 that I think would potentially be helpful is if there was some education, not necessarily for individuals that need to access the line, absolutely, but more so for individuals that are accustomed to calling 911 and they interact with individuals that are having a mental health challenge or a substance use challenge, teaching them why calling 911 no longer be appropriate. And in order for them to get the help that they need, how and why they need to dial 988. So I think there's education on both sides that would be helpful.
I totally agree. And especially in a lot of our rural communities where there's been such a heavy dependence on calling 911. And for a lot of people that still don't fully understand mental health, and they still view people with mental health challenges and people experiencing mental health emergencies as being violent or dangerous, and they're going to feel like they need a law enforcement presence. And that's not to say that there are not situations where it may be advantageous to have a law enforcement officer on site, but the rule of thumb is and should be that a mental health emergency should call for a mental health response. So again, I agree. I think we're trending in the right direction with that. But as we are approaching the time to wrap up, I do want to leave space if there's anything that you'd like to share that maybe we haven't touched on, any parting thoughts you have for our audience. I just want to give you the floor.
Oh, thank you. I guess my statement would go to those of us that are serving in this field. And it's an acknowledgement of that if you're in this field, it's not an easy field to be in. We don't have all of the answers, but I think that when we choose to work together, we choose to have conversations like what Vic is choosing to have with those of us that are in this field, we choose to be more self-aware, right, of what we're bringing to the table as providers, and we're choosing to acknowledge that people's experiences, their history, impacts how they present, right, will allow us to just be better servants of people, right? We have to honor where people have come from, right? So that we can truly show up genuine for them and they can show up genuine for us. So I really challenge anyone that's a provider to just always take a moment before you meet with any patient, any guest, any consumer, a moment of self-reflection so that you can show up genuine in that space and that guest or patient or consumer can show up genuine with you.
I think that is a perfect parting thought Akemie, I want to thank you so much for being my guest today. And I will tell you on a personal note, I am so glad that you and people like you are out there doing this work for such a vulnerable population. Thank you for you and your colleagues at Recovery Innovations for all the work that you do every day. You all are leaders in this space of um, crisis receiving centers and working with people with lived mental health experience. So thank you so much for what you do every day, and keep up the good work.
Thank you. I'm happy to work alongside you, Vic, always.
So thank you all for being our guest today on Strong Talk. Until next time, I'm your host, Vic Armstrong, and that is Strong Talk. For years, I've heard and used terminology like parity, equity, and integration as it pertains to mental health. We've talked about parity in the sense that we need insurance coverage of treatment for mental health and substance use disorders that is no more restrictive than treatment for illnesses of the body, such as diabetes and cancer. Yet, we continue to struggle with being able to hold payers accountable when payment for mental health services are denied or access is unavailable. We've talked about equity as it pertains to race, sexual orientation, and gender identity, access to care in rural communities, and access for individuals living with disabilities. Yet, we still lack interventions that are culturally relevant and accessible in communities where people live, work, play, and worship. A lack of access to care in rural communities, and a lack of access to resources with the cultural sensitivity. All right, I'm gonna start this over. That flubbed twice. I'm sorry. For years, I've heard and used terminology like parity, equity, and integration as it pertains to mental health. We've talked about parity in the sense that we need insurance coverage, treatment for mental health and substance use disorders that is no more restrictive than treatment for illnesses of the body, such as diabetes and cancer. Yet we continue to struggle with being able to hold payers accountable when payment for mental health services are denied or access is unavailable. We've talked about equity as it pertains to race, sexual orientation, and gender identity, access to care in rural communities, and access for individuals living with disabilities. Yet, we still lack interventions that are culturally relevant and accessible in communities where people live, work, play, and worship. A lack of access to care in rural communities, and a lack of access to resources with the cultural sensitivity and humility to address the needs of our LGBTQ brothers and sisters. We've talked about integration, physical and behavioral health, recognizing that many of the prevalent causes of death and disease are caused by behavioral and environmental factors. And we know that chronic health conditions such as diabetes, substance abuse, asthma, obesity, and cardiovascular disease require behavioral health interventions for best outcomes. Yet, we continue to have siloed treatment for those living with mental health challenges, intellectual and developmental disabilities, addictions, or traumatic brain injury. Perhaps part of the solution to building a better system lies in how we talk about system transformation. We often talk of parity, equity, and integration as if they are very different things, leading to siloed conversations with siloed expertise and siloed funding streams, much as we have a siloed care delivery system. The truth of the matter is that regardless of what we call it, we need a system that provides a whole person care approach, including physical, mental, spiritual, behavioral, and emotional needs. A system that provides access to care and resources that are culturally relevant, lived experience informed, and accessible in communities where people live, work, play, and pray. On that, we agree. I think we can also agree that the time for talking has long since passed. It is not a question of understanding what we need in the design of a more effective mental health system, but a question of whether or not we have the willingness, the wherewithal to put our resources and collective action behind creating that system. As with many things, the first step is perhaps not in the learning, but the unlearning. And that is Strong Talk.
What's the word? What's the word? Word, strong talk, strong talk. What's the word? What's the word? What's the Word, yeah, yeah. What's the word? Strong talk, strong talk.